So the alternate site for chest decompression, we're going to be, that's available to you, is the anterior axillary line and the fifth intercostal space. And that's about at the nipple line, and that's, the anterior axilla. So the reason we're doing anteriorly is if someone's on their back and they have a pneumothorax, rather than the mid-axillary line, is that air is going to be up higher. So we're going to want to access that. It decreases the chance of lung injury, because that air is going to be anterior. So in big CT scan studies of trauma patients, they measured the anterior chest wall at the second intercostal space, and the average was something like 3 point something centimeters. So that is like right at the depth of some of our catheters. So our old catheters wouldn't even get there. So thankfully we're carrying stuff that's pretty good. And in a lot of patients that this will reach. This is a 3.25 inch. So in a lot of patients this will reach in this spot. But if you look at their chest and it's obviously going to be inadequate, then you have this alternate site to go. So you come down from the, where the nipple should be anatomically, and to the rib here in the anterior axillary line, that's about the fifth space. And it's the same procedure. You just go over the rib. You want to avoid the neurovascular bundle, which runs under each rib. And it's the identical procedure. Part of the reason I think that we've had some unsuccessful deals is that when we put these in, someone has a thick chest wall, and we're putting them in, and we're getting in there, and then there's recoil in the tissue. So they have a lot of soft tissue. You kind of push down, you dimple that soft tissue, and then it recoils, and then the tip of the needle may be coming out, or the tip of the catheter once you remove the needle. So I've seen that fail in real patients in the ER. So that's why this is another alternate site. Same technique, just different site. There's a low risk for artery and blood vessel there. It's in the same place underneath the ribs. There is a nerve, the long thoracic nerve is way back here in the posterior axillary line, so we want to avoid that. But and that goes to your latissimus, your lats. So people want to practice that. This mannequin, I think, is set up for chest tubes, right? Is that what this is set up for?
Trauma services.
So you can actually poke through there if you want, but it's identical procedure, just an alternate location to use. So same catheter is fine. We do have some longer catheters, right? The 5 inch. So really big folks, that would be an alternative too. Of course, with that catheter, you do maybe run risks of hitting other structures in there. So you have to choose your catheter wisely based on the habitus patient. So, okay. Has anyone ever done the anterior axillary line decompression? Yeah. How'd it go?
Good.
No different?
Actually, yeah, I got better return. I had needled anteriorly in the second, third intercostal space, and chose.
Yeah. So what's nice is that's just past the border of the pectoralis to get around that. So if someone, you have one of these big bodybuilders like Trenton, and get around those massive pecs. Okay.
It's funny.
I was going to say Duffner, but he actually does so. Any other questions or concerns with that? People can try that up here if they want. You can do the standard one too.
Finger thoracotomy if we do multiple needles?
No, not yet approved, right?
Okay. Well, do you think?
Maybe someday. Montana doesn't seem like that's going to happen anytime soon to me.
Go across the board?
Yeah. So, yeah. But
A lot of places are moving to needle twice and then you do a finger thoracotomy.
So what he's talking about is a technique where if you have someone that is really sick with multiple trauma, some systems are actually moving straight to, they're doing needle decompression, but some ERs and resuscitation centers go straight to thoracostomy with the finger. So they prep the site like they do for a chest tube, they make a skin incision, and then they put a curved Kelly clamp in right over the rib, open up the chest, and if they get a return of air, they'll put a chest tube in later. So the idea is, and I think this is a good idea, it's something you guys should think about if you have someone with penetrating or blunt chest trauma, you have a high suspicion that they have pneumothorax or tension pneumothorax, and you're going to intubate that person. If you intubate that person first, there's a significant risk that they may get worse if they're already unstable. Because if they're developing that tension physiology, right, they're not getting good blood return to the heart, now you put them on positive pressure ventilation by either bagging them or putting a breathing tube in. And what does that do to your venous return when you start that? Yeah, it decreases. So you're increasing interthoracic pressure. Because normally, people are spontaneously breathing. They take a breath, the pressure inside their chest is negative. Now it's the opposite of that. It's positive. So you're further limiting venous return, and it's already compromised by tension. So there's a lot of centers that would decompress the chest before you manage that airway. I think that we should be thinking more about that, for sure.
Could you walk through traumatic arrest step by step for primary assessment and intervention? Like, do you still want us doing compressions on traumatic arrest? Is this correct?
That's understanding that your compressions are likely to be not working. So if they have tension pneumothorax, they have tamponade, or they have no blood left, and you're compressing their chest, you're not really circulating much blood, because you're sitting here, you're doing compressions, there's increased pressure, and then the recoil, that we're really focusing on recoil, right, with our high performance CPR. If you recoil and there's no blood to return, you're not getting effective CPR. That being said, there are some patients who may respond to some of these efforts, and the things I would think about, the way I would do it, was I would get someone on there trying to get access, another person would be compressing the chest, and someone else would be decompressing, and then I would manage the airway. I would do it actually kind of in that basic order, which doesn't sound exactly right, but if I have a bunch of people, that's how I'm doing it. If I'm by myself, I would probably, there's no pulse, I would probably try and decompress both sides of the chest, and then try and do some spontaneous breaths for them. And I wouldn't do compressions if I was by myself. If I have a limited number of people, there's all variations of that, of course, but I guess I would have someone, start compressions, someone decompressing the chest, and someone valve masking it. And then if you have more people, you can get the monitor on and see what your rhythm is. So if it's asystole and it's blunt trauma, you're probably done, and it wasn't a witnessed arrest, you're probably done regardless, especially if you're more than, 10 minutes from the hospital. Your chances of having any kind of outcome are super duper low without being able to do a field thoracotomy, which we're not going to do. Sorry, Trent.
It's becoming a standard. It is. There's many states that are doing it now.
Yeah.
So,
Yeah.
and if anybody's going to push the state to do things, it could come from
I'm
here.
just trying to get the eye gel right now, so what's attainable. But yeah, so that would be my approach. Is I would try and relieve tension, and then I would do compressions and manage the airway. I might do if I would assist ventilation at some means there.
That's one checklist that will be on there, will be the traumatic
Yeah.
arrest.
Yeah, so we tried to put that in there. That'd be good things to review, on your way to one of those, or someone who's critically, already know they're unstable and you're going to a trauma. So that's part, these things are super valuable. With that that paramedic book, I used to do that all the time en route to calls. I would look through it used to have that problem-based section, and I'd look through it and be like, okay, think about all this stuff. Yeah, I guess my mind working, so. And on the engine, we would review those things as a group. We'd be like, hey, we're going to, a hanging. Who's going to do what, and what's our, who's going to take what spot? What are we going to do, and what things we think about when we're going to some other problem. So those are good times when you're en route to start thinking about that. So to get your mind on the right track. So.